Okay, welcome everybody to today's SANDAS seminar. I'd just like to start today by acknowledging that I'm on Kaurna land today, that I work and live on Kaurna land and pay my respects to elders past and present. And I'd also like to acknowledge the traditional owners of the lands of wherever you might be dialing in from today. And pay my respects to and extend that respect to any Aboriginal people who might be joining us today, and acknowledge that this is land that was never ceded, always was and always will be Aboriginal land. Today we have a really exciting seminar presentation for you from a couple of AOD lived and living experience educators working at Insight, which is a Queensland's specialist provider of alcohol and other drug training, education, clinical resources and practice advice for workers and services. And whilst their work has been very Queensland focused and Queensland based, we thought that there's a lot to learn from our interstate colleagues from their project, and thought that it would be useful to share with you guys today. Just a bit of housekeeping. If you've got questions, please feel free to pop them into the Q&A function, and we'll get to them at the end of the presentation. And yeah, I think that's all. So I would like to introduce Brett Hodges and Matt Tipping. Brett has a social science background with a history of delivering harm reduction and case management services across Queensland, alongside his lived and living experience of AOD has led to his current role as an AOD lived and living experience educator with Insight. And Matt brings a broad variety of experience from his time working as an advanced peer worker across the acute mental health inpatient wards in Logan and PA hospitals. As an educator, Matt strives to reduce the stigma for people who use drugs when they are accessing services. So without further ado, I will hand over to Brett and Matt.
Well, thanks, Sam, and welcome everybody here today. Thanks for having us. I don't know how exciting our work is, but we're happy to come and talk about it today. Before we start, I too just want to acknowledge the traditional owners of the land, and we're here today presenting from the Turrbal and Yuggera peoples, and we just pay our respects to those and the lands and from where you might be listening today. Rather than going through it, we might as well look at the artwork. This is something Insight had commissioned as an artistic representation of what we do across Queensland. This was by Bree Buttonshaw. She's a Kalkadoon woman, so from up in the northwest of Queensland, Mount Isa country. The centre circle represents us coming together and sharing our knowledge and coming together and sharing our learnings and knowledge, and all around it is all the places that you might come from in Queensland, and I guess it represents whether it be rainforests or the desert or the coast or the islands or the cities, and just sort of leads into what we do here at Insight. Thanks for the intro, Sam. Yes, leading provider of alcohol, drug training and workforce development services. We're a very accessible organisation in that we try and make sure that everything that we do is available cost-free, even though there is some fee for service. Everything that you see on the workshop will be available as a resource for people, particularly those working with populations around alcohol and other drugs. We do a lot of e-learning, so we've over 100 e-learnings now, and these e-learnings are designed to be short, sharp modules where from introductory AOD concepts through to advanced worker concepts. You can jump on there, up in the top right-hand corner there, you can sign up and get a profile and have access to all of those e-learnings for free. Given that this week is celebrating Harmony Week, Insight will be releasing 3 new e-learning modules this week on working with culturally and linguistically diverse populations. Take your time. There's also one in there around AOD lived living experience, just an introduction to that. We deliver workshops across the state, and so whether it might be motivational interviewing or harm reduction or basics or crash courses or withdrawal guidelines, We deliver workshops across the state, again, free of charge, half government, half NGO traditionally in who attends these things. Similar to what we're doing here today, webinars. We have a back catalogue, about 5 years of webinars. So if there's anything that you're interested in, jump on and you can look through that library there. We also have videos and toolkits, brief intervention toolkits to work when you're working with people around different substances, different assessment tools, etc. Have a look through the website and see what you're. In the photo there, we've got, it is a very diverse, multidisciplinary team. We have nurse educators who've got long histories of working in the AOD sector. We have psychologists, we have social workers, we have occupational therapists, we have a First Nations team. And I guess at the start of 2023, Insight made the move to employ a lived living experience component to their organisation. And Matt and I were successful in starting that in 2023. So when we talk about a project, I guess our project has just been our employment to date, and we've tackled a few things that we'll get into and talk about today. But before we do that, I'd like to just recognise that many people with lived and living experience, including family members and allies, who have had to endure the stigma that still surrounds substance use, mental health challenges and suicidality. Also got to recognise the efforts of those that have come before us, those who have valiantly been working to enable the voices of lived and living experience to be heard in forums such as this one here today. 10 years ago, this wouldn't have been seen in the AOD sector. So we feel really privileged to come here today, but we also want to just respect the idea that there was many that came and forged this path before us. And so we've been really fortunate. And I guess, I suppose there's going to be a few of you in South Australia that are working as peer workers, perhaps in frontline positions, which is where we see a lot of growth these days in this AOD peer workforce. Our positions are not forward-facing. We deal with workers, so we don't end up doing a lot of service delivery per se. But Insight brought us on in a real spirit of how do we change our organisation using an identified lived living experience. And so we started off by co-designing, and rather than being given a list of things that they wanted us to work on, they essentially described it as an open landscape and spend some time working on this and populating this landscape. Try and look for where there's opportunities, look for where there's shortfalls or shortcomings or gaps in the system. We've worked on co-designing several e-learnings, workshops and webinars. We also work in co-developing workshops. So part of what they do at Insight is an ongoing review, formalised review process. And we come in and look at existing training material, and alongside clinicians and educators, our input is valued the same from the very start. When we're asked to participate from the very design through to the implementation, our perspectives have been valued and have been respected. We also co-review. So part of that review process is going through existing materials, whether they be e-learnings, webinars or workshops, and having a look at them and coming back and ensuring they're up to date, making sure that everything's current. But when they asked us as lived living experience workers to come along and provide our input, I can say without hesitation that all of our advice that we've ever provided has been taken and has been integrated into existing learnings. It's been a real pleasure for us to be able to come into an organisation where that has been accepted. We, in our consultation that Matt's going to talk to you about a bit later, that we've certainly heard many examples of where that might not be working as well as it could. So I guess we've got to just recognise we've been really fortunate. We also co-deliver, and so the workshops that run around the state, rather than being a psychologist and a nurse, so if there's something going out on withdrawal practices or relapse prevention management, one of us will accompany another clinician and deliver it as part of a team that recognises lived living experience has something to bring to create a richer learning environment. What it has done, all of this process, other than make me feel really lucky, is reinforce in me the importance and benefits associated with authentic collaboration. In that review process, we are regularly doing internal and external reviews on our education material, and the same way that people who provide advice and guidance to us and we take it, it's been accepted the same when we bring ours. This collaboration in the wider community, the important part there was that we were just two voices, and we've only got our own experiences to bring. And Matt and I, whilst we are very different, also are representative of a very, very diverse sector, a diversity of all those that bring an AOD lived living experience. So we've actively sought to engage with the networks of those with experience and sought their input around how we develop content and the direction of our projects. So we do this informally every day in our discussions. I don't know the landscape that well down there in South Australia, but we have several organisations that we are in contact with regularly that might have lived experience workers, might represent people who use drugs, might be peak bodies such as yourself with staff who are identified and sometimes in non-disclosed. Maybe they bring their lived living and don't want to disclose because of the stigma that still exists. But we also need to do this formally, and we did this around several projects that they're working on. What I'll do is I'll let Matt introduce himself and he can start talking to you about how we've gone in and tried to collaborate, and particularly around our formal collaboration. Thanks, Matt.
Thanks, Brett, and good afternoon, everybody, and thanks, Sam, for that awesome introduction for Brett and I really appreciate it. So I get to talk about our consultation process now to get to where we're currently at a year and a bit in. Just wanted to say, obviously, everything that we talk about is really based on the Queen, as Brett just said, the Queensland landscape for alcohol and drug lived living experience staff could be very different to what it's like in South Australia. But this is all based on our learnings and what we've been able to accomplish in these roles. Very important to first off talk about the fact that when Brett and I first commenced in these roles as educators with Insight, we embarked on an extensive literature review to really understand that the challenges and successes of integrating the AOD lived living experience workforce, not only just here in Australia, but also worldwide. So we did quite an extensive literature review. And then after the review, we then reached out to our existing network or networks, both existing and new, of AOD LLE colleagues and workers here in Queensland. That's across NGOs and Queensland government services that employ the AOD LLE workers. And that formed our consultation. So a bit of background on the consultation. So our consultation group consisted of 21 participants across 13 organisations. Importantly, to know that almost half of the consultation participants were in designated AOD LLE positions. So these roles, they could have ranged from AOD peer workers to harm reduction peer workers, and we also had a lived experience advisor on the in the consultation as well. We also wanted to understand the challenges and successes at a local level that came with the inclusion of the workforce. So we spoke to managers and coordinators and exec level management of organisations that currently employed the AOD LLE workforce or considering engaging with the workforce as well. So our initial consultation resulted in the development and launch of our e-learning. That was in June of 2023. Brett spoke about that before, but it is titled Understanding the AOD LLE Peer Workforce. On the screen right now, you hopefully will see a QR code. If you wanted to have a look at our e-learning, encourage you to scan that QR code and have a look at it. Obviously, create an account first with Insight. But even if you don't have the capacity to scan that, our website is insight.qld.edu.au. So that was insight.qld.edu.au. When you go to the home page there, there'll be an e-learning tab. If you click on that tab, there's a search bar. If you just type the word peer into that, you'll see that our e-learning will come up. So I guess this e-learning, what it's really designed is to provide examples of the workforce in action, benefits of including the designated AOD, LLE roles, and some considerations for organisations for successfully integrating the workforce. Also through the consultation, we also discovered that a lot of organisations had questions around things like role descriptions and training and recruitment. And one of the big discoveries was that many organisations come across challenges in not only including the AOD LLE workforce, but also retaining and keeping them safe in the workplace. So that sort of sparked our next phase of our Insight Lived Experience project, which was to design an organisational readiness tool. So let's look at a little bit of the consultation process for that. Again, we're all about the consultation. So this phase saw us engage a further 21 participants across 12 organisations. So those participants were both in designated and non-designated roles and ranged from team leaders, managers and executives. Our aim was to co-design a toolkit that builds and enhances organisational capacity to safely and successfully engage the AOD LLE workers. The toolkit will include a range of tools such as templates and job aids and resources, covering many of the topics that we identified in our consultation process. So there was things like recruitment, position descriptions, training and qualifications. I think I mentioned a lot of these before, organisational support, and importantly, supervision, which I might talk about that a bit later, but I don't know in South Australia, but in Queensland, there's one big lack that we have is access to supervision for AOD, lived experience workers. So, we see this organisational tool as an important step towards the development of a safe and supported workforce. Now, currently, our toolkit's in the final design stage. We've done all the work, just making it look good so that we can release that. We don't have a release date yet, but we are hoping that it will be released in the coming months. If you do want some more information about that, sign up to Insight, and I'm sure that once we have further news about that, that will be disclosed. So before we move in to the main section of our webinar today, which is the frequently avoided questions, I just wanted to provide a brief overview of our consultation thus far. So to date, our consultation has included 42 participants across 19 organisations. We had an equal split between organisations such as peak bodies, NGOs and government health services, with over a quarter of our participants being in designated lived living experience roles. As Brett said before, it's always really important to mention as well that we are committed to an ongoing consultation process. Research tells us that AOD education that is co-designed and co-produced in conjunction with people who use or have used drugs is considered best practice. I think it's now time to hand over Brett to start off the frequently avoided questions.
Thanks again, Matt. Still a little unsure about frequently avoided questions. It's not meant to be a hook, but I guess in all of this formal consultation, and particularly more so the informal consultation, we kept getting posed a range of questions that often were raised after the meeting, often were raised when we were sitting there having a cup of tea afterwards, where people were unsure and felt uncomfortable about asking some of these questions. And I thought, well, this is probably the best area we can work in, is trying to get some findings on all of these concepts that people are trying to avoid and sometimes are a little fearful of. And I think that when we include lived living experience, that there's all sorts of problems that might be associated with that. guess this is only our point of view, and we've taken this from the literature and the people we work with. I've got a fair bit written here, but I tend to rant on a little bit when we start talking about some of this stuff. And the first one is the biggie. What do you mean by lived living? And you'll notice in the title that we've actually used a hyphen to separate it. Rather than seeing them as unique terms, we need to start talking about this as an encompassing term. It actually came about from mental health peer work who have 2 decades of growth and development, and they're always known as lived experience. And a lot of this stuff was born in what we understood as lived experience, but mental health sector saw it as not being an inclusive term, that many people still today may have lived through events, but also still living with them. And so rather than excluding a great proportion of the mental health sector, they moved to using lived living as a definition. It's really frustrating for me. It's another acronym, AOD, LLE. It doesn't roll off the tongue very well, but lived living is the term that I use, firstly because I don't believe that our experiences in life are that delineated. If I've lived something, then inherently I'm still living it, and vice versa. Secondly, and more importantly, I use this because the terms lived and living are now used not as a reference to the unique and valued skills and experiences that we each bring as workers, but as this covert opportunity for people to define us once again by our drug use. AOD peer workers come from across the full spectrum of our community and bring with them and us a diverse range of skills and experiences. Each organisation is going to have specific needs around these skills and experiences that they want in their peer workforce. The conversations and requirements need to move beyond this idea of lived and living, and instead focus on the skill sets and experiences that will best suit the requirements of each work environment. Defining an individual's relationship with AOD by their job title is problematic and does not reflect the often fluid and complex nature of this relationship. It was a decade ago where we all realised that we move away from defining people by their drug use. The nature of our language and stigmatising language now, this has brought great change in our industry. Yet what was designed as an encompassing term and an inclusive term has now been hijacked, where lived or living or risk profile or any of these other fancy words that keep coming up is just another way of defining people about whether or not they use drugs currently. What we do know, if we look at the stats, all AOD workers have their own relationship with alcohol and other drugs. Recent statistics suggest that nearly 70% of people who work in the sector bring some sort of lived and living experience. As a AOD lived living experience worker, everyone will have their own relationship with alcohol and other drugs. For some, that might mean complete abstinence. Maybe this might also mean they just abstain from what was their primary drug of concern, or from substances altogether. Some from all psychoactive substances, including coffee and cigarettes. For others, it might be that they just no longer use during the week. Maybe they limit themselves to substance use on special occasions, New Year's, Christmas. Perhaps they limit themselves to drinking alcohol, lower alcohol options, and abstain from spirits or wine or full-strength alcoholic beverages. Others may continue to take a range of prescribed medications. Some may limit their use to days just ending in Y. Regardless of their relationship with AOD, each member of the workforce can bring an authentic and informed approach to complement existing service provision in the sector. So I leave this one as I encourage people to stop using the terms of lived and living as separate titles and think of it as an encompassing term, lived living, until we can get some sort of industry body who can come through and formalise this. This is just our little part of trying to break down what we know is sometimes a very segregated sector and some of the problems that come from this segregation, and moving into non-stigmatising territory where we don't define people by their drug use. That's what we mean by lived living. Why do we already need these worker roles when we already have workers who have disclosed AOD lived experience? I've been working in the AOD sector for 20 plus years. At times I've disclosed my lived living experience, in other roles less so, depending upon the employer often. What's been really good for me with Insight is being able to do this and have the confidence to stand up and declare a lived living experience of alcohol and other drugs and see the implications that have, rather than just having a job in the sector and talking about my experience. When we actually define our role by bringing this, brings implications not only for yourself, but for the benefits to a service. We know that recent surveys have revealed that, I said 70% last, let's say 65% of workers identify as having a lived experience of AOD, either personally or through significant others' experiences. This has undoubtedly led to better informed service design and delivery, as individuals can use their lived experiences in their areas of expertise. The introduction of a designated lived living experience workforce does not challenge the status or benefits that many workers in the industry have historically been providing. As the personal experience of AOD workers who may or may not choose to disclose does not define their role in the same way as peer workers. When you're a peer worker, you're defined and you bring with it, you are therefore designated as bringing a lived living experience. We know in traditional senses and in the sector, many allied health professions have cautioned around disclosure, particularly when it's around problematic times in their life. When you're hired as an AOD lived living experience worker, the role, by the nature of the role, you're often required to share stories, whether that be about building relationship or modelling hope or providing credibility. The disclosure and the integration of peer roles, where the people who use your service are provided opportunity to engage with people like myself or others who have experienced similar journeys, is what dictates the need to actively include these roles. This level of connection and support has been proven to lead to better engagement across the world and within Australia. We also know that providing the opportunity for people with lived living experience of alcohol and other drug use to model work behaviours and values directly challenges the stereotypes that persist around people who use alcohol and other drugs. So similar to the mental health development of 20 plus years, where we put people in roles where people can say, I live with mental health, but I'm here still providing benefits. And you can see me as an example of that, is the same reason putting people in AOD peer roles and giving them enough scope to prove that still very valuable members of what we can do and bring great benefits to organisations and to outcomes of the people we work with. Oh, crikey. The World Health Organization still sees that illegal substance use dependence is the most stigmatised health condition across the globe. Recent reports from the Queensland Mental Health Commission found that stigma that surrounds AOD use is pervasive and widespread across many service delivery areas, including in health settings. I'm not going to suggest that it's the same in South Australia, but from our experiences, and from the people we talk to across Australia, stigma still controls a lot of the work we do. there's a lot of fear around declaring a lived living experience. So the integration of this workforce demonstrates an opportunity for organisations to actively challenge this stigma by demonstrating outwardly their commitment to this community and by providing clear examples within their organisation of people with lived living experience making contributions at all levels. It's only by championing these roles that we can address this stigma, as keeping employees as covert operatives, providing the lived experience benefits in relative anonymity has historically not been able to do so effectively. Challenge stigma. We know it exists. How can we do things? We can change our language. We can change some of our work practices. But until we start putting people out there as challenging these stereotypes that exist, personally, I feel it's one of the greatest steps we can do to change people's individuals' hearts and minds. Matt, I'm going to hand over to Matt for this one.
No worries. Thanks, Brett. Excellent. All right, so run through a few questions that I find fairly important to talk about. First one being, are AOD LLE workers likely to relapse and therefore take time off and be less reliable? Pretty much all AOD LLE workers that I've worked with have developed effective strategies that support them to either maintain abstinence from a problematic substance or to engage in harm reduction techniques to avoid potential harms. Evidence suggests that people with lived experience who are engaged in an active work capacity are less likely to experience problematic substance use that they may have experienced during periods of prolonged unemployment. But while there's no guarantee that an AOD LLE worker is not going to change their relationship with AOD whilst employed, similarly, there's no guarantee that existing staff will not experience changes in their AOD use, impacting on their work performance. Research suggests already, as Brett said, that there's a large proportion of the existing workforce who already use AOD, and that may occasionally see staff accessing personal leave. I always like to think of events like Melbourne Cup. How many people have a sick day the day after Melbourne Cup? Same sort of thing. But amazingly, a lot of what we're talking about here was backed up through our consultation. When a senior manager of one of the organisations commented that on occasion there's been greater incidents with existing staff rather than the AOD LLE workers regarding changes to AOD use, resulting in a reduced work performance or accessing leave. So I guess the way we should really look at this is all employees. It could be, clinicians or, even the AOD LLE workers will need to access time off for personal leave because of illness, or either for themselves or for a family member, or compassionate leave at some stage. So worker expectations around this shouldn't be seen as any different. It should be the same for everyone within an organisation, regardless of their role or position. Moving on to the next one. This is a big one that we get a lot, is how long a period of recovery is required to be an effective AOD LLE worker. And the reason to say this is a big one is, and I'll talk about this a little bit further on, is that I have a few years experience working as a peer worker. One of the, I don't know if this happens in South Australia as well, but one of the requirements in some settings would be a level of recovery or abstinence or whatever it is before you can hold employment. But the way I like to look at it is everyone will have different experiences and understanding of what recovery can mean. Length of time in recovery is not an indicator of how effective an employee can be in a role and doesn't directly correlate with the employee's abilities. Contemporary understandings of the concept of recovery acknowledge that abstinence is not necessarily the basis of recovery, with many individuals choosing different relationships with drugs and alcohol and still defining themselves as in recovery. This could include a reduction in use, pretty similar to what Brett was talking about before, choosing to use different substances or safer using practices, or even certain forms of abstinence that are important to that person. So rather than focusing on the worker's time since changing their relationship with alcohol and drugs, effort should concentrate on assessing an individual's capacity to be an effective person within that role. Now, whilst I have to admit, whilst some organisations, as I spoke about before, will require AOD/LLE workers to have first-hand experience of certain treatment types and settings, it's important to recognise the unique nature of recovery, and that individuals will have differing experiences of this. There are many workers from across the AOD/LLE workforce and within the existing workforce, as we spoke about before, who continue to use alcohol and other drugs and still provide effective and valued service contributions within all of our organisations. Here's a big one for everybody to digest: are people on opioid dependence treatment programs able to work effectively? So ODTP medications, or opioid dependent treatment program medications, are widely recognised as an effective treatment for those with opioid dependence and seen by the World Health Organization as essential medicines. They should not be seen as any different to any other prescribed medication in the workforce. Existing workforce will already be taking prescription medications for a range of mental health and physical conditions. Organisations will often already have drug and alcohol policies and guidelines, both for employers and employees, around the use of prescription medications. Whilst both methadone and buprenorphine can cause some levels of impairment early in the treatment, the purpose of these medications is to allow individuals to avoid intense withdrawal symptoms and cravings and to function long-term without impairment. The challenge for a lot of AOD/LLE workers they face is accessing the ODTP medications whilst employed. Now, these sort of challenges have been clearly documented. Again, not too sure about South Australia, but there is a lot of issues around prescription of ODTP here in Queensland. And we often find that people that are on the program, they may, many of them may access their medications through community pharmacies, and they're also often facing restricted opening hours that often will coincide with their work hours. And so there's also the need to travel to pharmacies that can be located far away from their place of employment. So this is something that, rather than being seen as insurmountable, these sorts of challenges should represent an opportunity for employees to support workers with reasonable adjustments around structured breaks and working hours to facilitate the worker accessing these medications. We already make massive reasonable adjustments for people that are on mental health medications. If someone is on the ODTP medication program, they shouldn't be seen as any different. And that's something that we should always keep in mind in regards to the ODTP medications. Okay, here's a big one that's close to my heart. So how are AOD/LLE peer workers different to mental health lived experience peer workers? So again, this is just mainly my experience. So if we have any mental health peer workers, this is not meant to offend. This is just my own lived experience of working. Bit of my story I've said before, I've got a fairly long history of working as a peer worker in hospital settings and inpatient hospital settings. Before coming into Insight, that was. And whilst I was employed as a mental health peer worker in those roles, I actually utilised more my lived experience and living experience of alcohol and drug to support people than mental health, because we would get a lot of people that would be admitted for co-occurring, alcohol and drug and mental health. So I was able to sort of effectively help those people. So I'm very aware of the challenges and differences between working as an AOD peer worker and a mental health peer worker, particularly around disclosure. I think that was one of the big things that I would always pick up on. There's an added layer of complexity for AOD/LLE workers, such as the potential risk around disclosing criminalised activities, and that very real stigma that Brett spoke about before that still exists around people who use drugs. Often our services see mental health and AOD lived living experience workers as the same. And although these roles share a lot of similarities in the way that, we share our story with people to support and inspire hope and build mutual relationships through an understanding of similar experiences, AOD LLE workers will have very different conversations with the people they support, particularly around ways to reduce harms if they are continuing to use or choosing to use, things like overdose risks. We may get in conversations about overdose, and even exposing ourselves to conversations around illicit substance use as well. So there's a lot of different differences between the two roles. Another big difference that I've found as well is that mental health peer workers and AOD workers will also have a very different understanding of the word recovery. Mental health peer workers often provide support focused through a recovery-orientated practice. So recovery in mental health focuses on that self-determination, social inclusion, hope and optimism about the future, identity and empowerment. In the AOD field, while these fields are also true, these principles, are also true, it's also, we also have to include the recognition that there are many pathways to recovery and that recovery exists on a continuum of improved health and wellness. AOD LLE workers understand that not all individuals they support will have a recovery goal of abstinence from AOD, and they may be looking to change their relationship, as we mentioned, or with a substance or with multiple substances. AOD LLE workers utilise their unique lived experience in many different settings that you won't find mental health peer workers in, and they may be employed in rehabilitation settings. It's a classic example, drawing from their own experiences of recovery and relapse prevention strategies to provide support. They could also be employed in harm reduction settings, using their sound knowledge of overdose risks and responses, as well as harm reduction strategies to work with people where they are. We recognise that the mental health peer workforce is well developed and supported workforce, particularly here in Queensland. The mental health peer workers have paved the way definitely for the AOD workforce. And we are growing slowly here in Queensland, but importantly, the mental health peer workforce should be celebrated for their successes. There's much that we can learn from their successes and grow as a workforce because of that. And one last little thing that I did want to talk about, and again, this could be a Queensland thing, I'm not too sure, but one of the big differences I find when we're talking about how well established the mental health peer workforce would be around supervision. We have a lot of supervision provided for mental health peer workers, but it's not so apparent for AOD workers, lived experience workers particularly. And again, there's, keeping staff safe, especially in that supervision. I know from my own personal experience and as a worker, disclosing and having different conversations in supervision, particularly around disclosure and boundaries and self-care and harm reduction with AOD, is a different conversation. So I think that's one of the big things we really need to foster within organisations, is that provision of supervision specifically for our workers that are designated AOD roles. I think that's me for now. I'll back over to Brett to have a chat to you some further.
Thanks again, Matt. I guess it's good you just brought that up. I'll just go back to what you were just talking about there, if you don't mind. We do know, and I guess it's really poignant because we're about to release 2 new e-learnings in the coming months, one around disclosure and one around self-care for alcohol and other drug living experience peer workers. In developing those e-learnings, it becomes very clear that there's a lot of specific stuff that applies only to those that are working in an AOD sector or bringing AOD living experience. Like Matt said, having a professional supervision session and what might come up in those supervision sessions for an AOD worker might be very different for someone with a mental health background. When we talk about boundaries, the boundaries we set as an AOD peer worker have an added layer of complexity on top of what, and mental health peer workers already have a lot of issues with boundaries. There's another layer of complexity. Self-care, similarly. You would think a self-care module would work across all sectors, but how do we do, what are the things we do to look after ourselves and keep ourselves safe? Yet in developing it, we've realised there is many areas that are specific to AOD. So what are other questions that we keep getting asked? Won't they say the wrong thing? I hear this a bit, that people hear peer workers having conversations and they assume that perhaps this isn't appropriate. And I guess, well, how does that come about? It is correct. This workforce will have very different conversations with the people who use your service than you may be used to. And when I say you, I'm talking about the rest of the sector, the clinicians, the allied health staff. But this doesn't mean that these conversations are the wrong things to say. As peer workers, got a different type of engagement with service users than traditional client engagement. Traditional client engagement operates with clear boundaries, often with no self-disclosure, or self-disclosure is not advised. Where AOD LLE workers will often use common language, sharing of experiences to develop a rapport. That can be perceived as the wrong thing when viewed from a clinical perspective, where it's specifically this capacity to relate and engage that's providing the benefits for clinical staff. When we bring in AOD LLE peer workers, it's a great conduit for information and translation of ideas, whether it be from clinicians to service users or service users to clinicians. AOD peer worker roles will not generally be involved in the provision of clinical advice around medications or treatment plans, though they will often need to discuss these with service users to ensure that they understand and improve the likelihood of treatment adherence. Recent studies suggest that AOD LLE worker roles can effectively provide evidence-based interventions whilst adhering to the fidelity of both the process and the unique nature of the role. An organisation should have a clear understanding reflected in their role description around the support and nature of engagement that AOD LLE peer workers provide. First of all, this enables the workers themselves to understand what they need to do, and also provides the wider workforce clarity around the nature of conversations peer workers will be having with people who use the service. Peer workers are meant to be having authentic, sharing, mutual conversations. This doesn't mean they're the wrong thing to say. It's just different to what might be used to in a traditional clinical environment. Ooh, they might be fragile. Aren't they going to be able to handle the stress? Look, if anyone's been in this sector for a long time, we're going to understand that this is a demanding environment. It does see higher risks of stress and burnout amongst all staff. Across the sector, many workforces will, nearly all, have a range of support and supervision measures available to them to ensure their sustainability and safety. AOD workers, LLE workers, also require these support measures, including reflective supervision and appropriate line management. Across clinical practice, many workforces require professional supervision with a peer from within their field to meet their registration or their membership obligations. We know this. Similarly, the AOD workforce could benefit or needs that same opportunity to reflect on their practice and self-care strategies. This happens for us, that coming in as living experience workers into Insight, we come under an administration stream. That administration stream is not afforded any professional supervision or professional development leave. We're fortunate, once again, that Insight's gone to bat for us and been able to source that for us so that we are appropriately supervised and that we can participate in professional development opportunities as they arise. But we're still locked into a stream that normally wouldn't have that. What we can know without certainty is that AOD workers are far from being fragile. Most will have inherently lived through many challenges and often developed a really strong resilience and understanding of all the stresses that can accompany service delivery settings, often haven't been through them themselves. So what is important is ensuring that an AOD lived living experience workforce has access to the specific training and reflective supervision that we know is critical in keeping the whole sector safe. It just needs to apply to peer workers similarly. I think we're going to run out of time here. And so I know that a lot of people do explain it being complicated, but more often than not that comes up is people say, but what about the cars? And what can we do when we're employing peers and we won't be able to let them drive? Like that wouldn't be appropriate. Well, let me tell you, most organisations already have workplace policies regarding the use of motor vehicles. This sets the expectations for everyone, for all employees around the user. If we reflect back on some of the statistics we talked about earlier, we know many people in the AOD sector have a lived living experience, whether they declare it or not. If an employee feels that their current substance use may interfere with their ability to operate a vehicle, then the onus is upon them to declare this. Existing policies should apply across the whole breadth of the existing workforce equally. There shouldn't be any extra measures that apply specifically to those with lived living experience. In Queensland specifically, they advise that no one should drive or operate machinery after taking illegal drugs. Also included in this advice is a range of commonly prescribed or over-the-counter medications that can affect your driving. If the integration of this workforce raises concerns around the use of vehicles and the exposure to the risk, then consider those statistics that more than 2/3 of AOD workers already have some form of lived experience. 34.5% of all AOD workers having a personal lived experience. This suggests that the integration of an AOD lived living experience workforce presents no further risk around vehicle policies than what your existing workforce could be perceived to present. Ideally, all organisations will continue to have open dialogue with all staff about the concerns that substance use can present when operating organisational vehicles. Thanks, Sam. Thanks to the audience. I might ask Matt back up, and I guess in the spirit of lived experience and peer work, we really would encourage questions. And I mean, we're also open to, if people have ongoing inquiries, please, we'll give an email in the chat, and we're happy to take inquiries if you need further information.
Fantastic.
Stop sharing.
Thank you, Brett and Matt. That was super interesting. And we do have a few questions and a few comments, but people who haven't put anything in the chat or the Q&A function, please feel free to do so as we go. The first was Carol, who was responding to your discussion about the term lived living experience. And she says that lived and living, the use of lived and living is to separate people who no longer use from people who are still using. And she felt that it's important that people who are currently using and engaged with the using community, so perhaps in a harm reduction role, that they have a voice and a place in the sector. Otherwise, the sector can be full of people who no longer use. So the focus is very much on abstinence, etc. So I wonder if you'd like to respond to that.
Absolutely right. What is happening though is we recognise the need for all people with their experiences to come along. And if we talk about a harm reduction scenario, then yes, the conversations you would have with your employees would be about finding skill sets that match. When we talk about lived and living, and we have this clear delineation of, oh, well, if you're living, therefore you use, well, what substances do you use? Is that only meth and heroin, or is that cannabis, or is that the breadth of the continuum of alcohol and other drug use? No one really falls into a clear delineation. I know people who are completely abstinent of heroin and have been for many, many years, yet they still choose to use other drugs. Does this put them into lived or living? So what we're trying to do is to avoid that divide and see us as a combined workforce with very different skills to bring. And similarly, that someone who works as a social worker might have a great deal of experience with people who are incarcerated. And then you might have someone who is a social worker who has a great deal of experience with working with people in the community. Both have different skills to bring. They're still social workers. And so I like to think of all of us as AOD, LLE workers, just with different things we can bring.
Great. Thank you very much. Penny has left a few comments that you might like to respond to. Firstly, she said that she often gets offended by the suggestions that she might relapse as a lived experience worker. I think we can all agree that's a shocking experience of stigma. And then she says, "Oh my God, the recovery question." So expressing some frustration. That exactly to your point, it should be relevant to all other people who work in these services. There's no other employees that have to declare their sobriety or time recovered from illness in context of effective work productivity. And then she acknowledged, well, maybe they do in some circumstances, but it's nothing like the AOD peer and LLE perspective. So she was very much agreeing with you there. And that, yes, her experience of people overhearing her conversations with clients do get a bit judgmental at times. So I guess to your point that, yes, the conversations that our peer and LLE workforce have with clients is going to be different to perhaps what the rest of us are used to. So, yeah, she's very much backing you up there. And then lastly, Michael White, who is the Executive Officer here at SANDAS, pointed out to everybody that we are very much interested in working with people who are interested in establishing a living experience or users representative body in South Australia. So something similar to AVIL or NUA or Quiver in Queensland. But currently we don't have such an organisation in South Australia. I believe we're the only state without one, which is a bit of an embarrassment. That we're really interested in working as an ally with people who have interest in setting something like that up. So please get in touch with Michael if we can help people champion that cause. We're very interested in doing so. I have no other questions in the chat. This is your last call. We're nearing the end of time, but this is sort of last call for any questions. I guess what really sat with me is I guess that sort of almost tension that exists that you pointed out between identifying someone as an LLE worker sort of identifies people by their drug use almost inherently. And I've heard lots of people, Annie Madden, who's done decades of work in this space, often talks about walking around with a giant label on her forehead unintentionally. So, and that's something that people in this workforce that can't always get away from. So there's kind of a tension between the benefits of naming those positions, but also the stigma that inadvertently creates for people. So I think that's a great acknowledgement of that tension, and I think that's something that the sector continues to grapple with, and that we should think very carefully about how we do that. So
absolutely.
Yeah.
Yeah, and it's like the comment about the disclosure, as I said before, working on the wards as a mental health peer worker, but helping people around alcohol and drugs, I'd often get into conversations with people, and then later on a nurse or one of the doctors would pull you aside and say, "Oh, should you be talking about that sort of stuff? We don't want them to use drugs anymore because they're on medication." It's like, well, I'd rather have a conversation about keeping someone safe than just avoiding it altogether. And so I think, that's where it's really important to have those designated AOD roles where people can have those conversations, or is an expectation where we will engage in those conversations with people, about substance use.
Yeah, and people can bring a real unique sort of authenticity to those conversations, I think.
Absolutely.
From an LLE perspective, Great. Carol's just popped back in to mention that that we use the term harm reduction peers to differentiate from sort of recovery abstinence focused peers as well. So
if I might, we've only got a minute, but I agree, and I see this is happening in a lot of jurisdictions where we're having now harm reduction peers and then recovery abstinence peers. When we talk about hospital settings and we talk about inpatient wards where we cater to the diversity of the community, we need both. And this is why in Queensland we're trying to say, let's have a unified workforce, because otherwise we're then going to say, oh, hold on, welcome to the service, Sam. Tell me where you're at, and we'll work out which peer you're going to have come in front of you. We're hoping that peers, both peers from across the spectrum, across the continuum, have the skills to be able to work with everybody. And to be able to often, yes, if you do have a great recovery story, you might have a lot of skills in a certain environment, but most of the people employed in AOD peer roles in Queensland fall into the HHSs and therefore are working with everyone. And so we're trying to say, let's have a combined workforce that can meet the needs of everyone rather than trying to differentiate. It's just about having AOD experience. So she's not wrong. I'm not saying it's wrong. I'm just saying in Queensland, in our context, most of our stuff is across what I would think of as a community and therefore needs a community approach.
Yeah, I suppose it really depends on the context that you're working in, isn't it? So, yeah, I guess mostly we're thinking about our workforce at this stage as working in drug and alcohol services. So, and often harm reduction services are sometimes separate from services that focus more on treatment or reduction or even abstinence. So, but yeah, absolutely right. You're talking at the level of a hospital or a broader health service, which I agree drug and alcohol service provision should absolutely be embedded in. So, you know, when you're talking about that broader context, then it becomes far more important for people to be kind of multi-skilled in that. So, yeah, I think that's a great thing for us to head towards, is having peer workers embedded in our hospital system or in our broader primary healthcare system for sure. Yes, Carol just made the point that it can be hard for people who are no longer using to provide safer injecting support and that kind of thing. So that really comes down to context, doesn't it? So people will be appropriate for employment in different areas, just as the broader community is. Yeah, absolutely. So
yeah, and I guess, and again, like I'm not disagreeing with what she's saying, but I guess like as a mental health peer worker, I'd have to support people around all sorts of things, and it's more about directing them with the information that they would need. So you know, if I found it triggering, I might say, well, then here's some information about an NSP that can help you to find information about safer injecting practices. So it's more about directing people. So that's the way I sort of think of it, just adding to what Brett was saying about, you know, multi-skilling. So if you've already got some lived experience and living experience in alcohol and drugs, it more about, if you're supporting people, it might be just directing them then to the right information they need to support themselves. But I can understand how it's triggering, and the reason, again, I know we're over time, but I've often told a story about how I was supporting an individual, and they started telling me different ways to use things that you could just buy at the supermarket. And before I knew it, I was at the supermarket thinking about using this certain, I don't want to obviously say what it was, but I found myself triggered by that. And I started thinking about it, you know, and I didn't want to go back down that. So I can see how, you know, something can be triggering, you know, and so, yeah, I can completely agree, and you know, can see exactly what the comment is. But I guess what we're trying to say is if you've got staff that are able to direct people to the information they need, that could be where it lay. And
again, it just comes back to the kind of understanding and support that we're providing for that workforce, that it should be no different to anything we're providing for other employees around that stuff. It's exactly the same. Excellent. Absolutely. Right. Well, I'm aware that we're a few minutes over time, so
thanks, everybody.
No other questions in the chat. I'll call time on that. But thank you so much for your time today, Brett and Matt. We really appreciate it.
Thank you.
And thanks everyone for attending. We've got one more seminar left in this series next week on Vicky Koch is from DASA, Clinical Director from DASA, is attending to talk to us about vaping and some of the changes in legislation in South Australia. So please join us if you can. Thanks again to Brett and Matt, and I wish everyone the fabulous rest of the day. Thank you.
Thanks, everybody. Thanks, bye.